Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we have the collaboration of Dr. Julia Seller, a clinical cardiologist attached to the heart failure unit of the Hospital Marina Salud in Denia. And together we are going to review the most important pathophysiological aspects of heart failure with preserved ejection fraction. Join us! As you know, heart failure is a clinical syndrome characterized by the presence of typical and not so typical signs and symptoms that occur as a consequence of a reduction in cardiac output and/or an increase in intracavitary pressures, and all this due to an alteration in the structure or functioning of the heart. Although we normally associate this clinical condition with left ventricular systolic dysfunction, we must know that, according to clinical activity records, more than half of patients with heart failure may have a preserved ejection fraction. Okay, we already know that the ejection fraction is not the most accurate tool when it comes to evaluating left ventricular systolic function. However, it is the most widely used clinical tool to recruit and assign patients in clinical trials developed at the field of heart failure, because in addition to being accessible and easy to use, it has prognostic and therapeutic implications. Thus, the clinical practice guidelines consider that a patient with heart failure has a preserved ejection fraction when the ejection fraction is higher or equal to 50%. In this way, when we compare the clinical characteristics of these patients with respect to the clinical characteristics of patients with reduced ejection fraction, we can observe that the former tends to be older, predominantly women, with a high incidence of arterial hypertension, diabetes mellitus, obesity, chronic kidney failure, anemia, and atrial fibrillation, while the incidence of coronary disease and ischemic heart disease is significantly lower. So, it may seem that heart failure with preserved ejection fraction and heart failure with reduced ejection fraction are two completely different clinical forms, since they do not only differ with respect to the previously mentioned epidemiological characteristics, but also differ in terms of prognosis and clinical response to treatment. However, truth is that, to this day, this issue is not entirely clear, as some authors suggest that both forms of heart failure could simply constitute different evolutionary stages of the same clinical process. For these reasons, different work groups have dedicated much time and effort to the study of the pathophysiological aspects of heart failure with preserved ejection fraction. Thus, in addition to diastolic dysfunction, it is currently recognized that this clinical entity may be caused by the interaction of various cardiovascular risk factors. Let's take a look. Let's start with diastolic dysfunction. You see, diastolic dysfunction refers to the inability of the left ventricle to fill quickly and completely during diastole, thus being unable to maintain normal filling volume or pressures. Classically, the triggering factor has been considered to be any increase in left ventricular afterload, since this would trigger an adverse remodeling of the cavity, characterized by concentric myocardial hypertrophy, increased wall thickness, increased myocardial oxygen consumption, and progressive reduction of the elastic properties of cardiac muscle. However, some authors defend that diastolic dysfunction may respond to a systemic pro-inflammatory state. In this case, arterial hypertension, diabetes, and other cardiovascular risk factors would cause inflammation and dysfunction of the coronary endothelium. This would reduce the concentration of nitric oxide and would produce local ischemia due to microvascular damage. It would induce myocardial hypertrophy, proliferation of myofibroblasts, and collagen synthesis in the extracellular matrix, all of which decreases myocardial relaxation and increases ventricular stiffness. Atrial dysfunction. As you know, the left atrium not only contributes to filling the left ventricle during diastole, but also acts as a physiological barrier between the left ventricle and the pulmonary circulation, as it protects the pulmonary vascular network from the wide pressure oscillations that the ventricular cavity suffers. For these reasons, the anatomical and functional alterations of the left atrium in patients with heart failure with preserved ejection fraction have been associated with the occurrence of adverse cardiovascular events during follow-up. Thus, decreased suction, increased passive stiffness, and decreased left ventricular compliance increase left atrial diastolic pressure. This pressure overload triggers left atrial dilatation and dysfunction, significantly increasing the risk of atrial fibrillation. In this way, The absence of useful atrial mechanical activity in patients with atrial fibrillation aggravates diastolic dysfunction and produces a decrease in functional capacity, regardless of the chronotropic response of the left ventricle. Left ventricular dysfunction and pulmonary hypertension. As you know, the increase in left ventricular filling pressure favors retrograde venous congestion. This not only dilates the left atrium, but also induces pulmonary hypertension in more than half of the cases. In fact, pulmonary arterial pressure is itself a prognostic marker of the disease, since the estimated mortality at 3 years of follow-up in these patients can rise by 28% for every 10 millimeters of mercury increase in pulmonary pressure. For its part, chronic obstructive pulmonary disease as well as other coexisting pulmonary diseases can contribute to the worsening of pulmonary hypertension, exercise intolerance, and mortality. Similarly, the existence of right ventricular dysfunction is frequent and can affect 1/3 of patients with pulmonary hypertension and heart failure with preserved ejection fraction. Although this phenomenon is closely related to the severity of pulmonary hypertension, the increased morbidity and mortality associated with right ventricular dysfunction is independent of the degree of pulmonary hypertension. Finally, during exercise, a functional decoupling between the right ventricle and the pulmonary artery can occur, which could significantly contribute to the worsening of heart failure. Plasma volume expansion. Plasma volume expansion has been associated with dilatation of the right chambers and the left atrium, favoring the increase in global cardiac volume regardless of the size or function of the left ventricle. And as you can imagine, all of these can increase filling pressures through mechanisms such as pericardial restriction and diastolic ventricular interdependence. In this regard, some authors have shown that in patients with morbid obesity and heart failure with preserved ejection fraction, there may be a significant increase in pulmonary capillary wedge pressure as a consequence of plasma volume expansion. Alterations in the skeletal muscle. As you know, patients with heart failure can suffer a series of morphological, metabolic, and functional alterations at the level of the skeletal muscle tissue, whose usual clinical manifestations is usually asthenia and exercise intolerance. Thus, it has traditionally been considered that skeletal muscle tissue atrophy and decreased functional capacity could be a direct or indirect consequence of heart failure due to a series of specific pathophysiological mechanisms, such as reduced blood flow muscle, systemic inflammation, increased plasma concentration of catabolic hormones such as cortisol, and decreased plasma concentration of anabolic hormones such as testosterone. However, it is becoming increasingly clear that musculoskeletal myopathy may not be just a consequence of heart failure, but may also condition the development and progression of this disease. Thus, the concept of skeletal muscle as a secretory organ has been gaining more and more strength nowadays, since the cardiovascular benefits of exercise significantly exceed the benefits attributed to the improvement of muscle mechanical function. But what secretions are we talking about? Well, basically we are talking about a series of muscle cytokines called myokines. Thus, myokines are molecules produced by skeletal muscle during muscle contraction. They are released into the extracellular space, and for this reason, they are capable of exerting autocrine and paracrine functions locally. However, these molecules can also be released into the systemic circulation in order to exert a peripheral endocrine function. For this reason, they are capable of favorably regulating lipid metabolism and conditioning the creation of a systemic anti-inflammatory environment. Thus, some authors have proposed that certain alterations in the production and release of myokines could contribute to the development of musculoskeletal myopathy, as well as to the development of other metabolic and inflammatory disorders classically associated with heart failure. This explains why different clinical studies have shown that physical training can increase oxygen consumption and improve functional capacity in patients with heart failure, both with preserved and reduced ejection fraction. Chronotropic incompetence. Chronotropic incompetence is defined as the inability to increase heart rate appropriately during exercise. This reduces cardiac output and prevents the body's metabolic demands from being fully met. Although the Fox-Strand formula has traditionally been used to determine the maximum heart rate predicted by age, a more robust concept called heart rate reserve has recently been introduced. Thus, the heart rate reserve is calculated from the relationship between the heart rate at rest and the maximum heart rate. In this way, a patient is considered to have chronotropic incompetence if the heart rate reserve value is less than 0.8. Thus, some studies estimate that chronotropic failure is present in approximately 3/4 of patients with heart failure with preserved ejection fraction. Although the pathophysiological mechanisms responsible for chronotropic incompetence are not entirely clear, it is suspected that elongation of myocardial fibers, activation of the renin-angiotensin-aldosterone system, myocardial hypertrophy, and chronic overstimulation of the sympathetic nervous system could trigger desensitization and loss of regulation of cardiac beta receptors, as well as adverse remodeling of the sinoatrial node, characterized, among other things, by the prolongation of the nodal refractory period and sinoatrial conduction. In any case, the existence of chronotropic incompetence in patients with heart failure with preserved ejection fraction has been associated with impaired functional class and high risk of adverse cardiovascular events during follow-up, including, among other things, an increase in mortality and hospital readmissions. Very well. After carrying out this brief review on the most important pathophysiological aspects of heart failure with preserved ejection fraction, the diagnostic algorithm proposed by the European Society of Cardiology will be much more understandable. Are you ready? Let's get started. The first thing we must do is to identify if our patient has signs or symptoms of heart failure, and for this, it will be necessary to carry out a good clinical history and a set of basic complementary tests such as an electrocardiogram, an analysis, a chest X-ray, and a transthoracic echocardiogram. As you can imagine, the idea is to rule out other causes of dyspnea and heart failure, such as left ventricular systolic dysfunction, valve disease, ischemic heart disease, lung disease, among others. In this way, and ruling out all of the above, we can suspect heart failure with preserved ejection fraction when there are signs and symptoms of heart failure in a patient who presents elevated proBNP values despite having a normal left ventricular ejection fraction, as long as the existence of a concomitant structural or functional cardiac abnormality can be demonstrated. But what alterations are we talking about? Very simple. We are talking about left ventricular diastolic dysfunction and the rest of the alterations described in the pathophysiology of the disease. So, as you can imagine, these alterations are left ventricular hypertrophy, reduction of the global longitudinal strain of the left ventricle, dilation of the left atrium, reduction of the velocity of the E' wave at the level of the mitral annulus, increased E divided E' ratio, peak tricuspid regurgitation jet velocity higher than 2.8 meters per second, or pulmonary artery systolic pressure higher than 35 millimeters of mercury. With all this data, the European Society of Cardiology has proposed a diagnostic algorithm with minor and major criteria that add up to 1 and 2 points each, respectively. Thus, we can say that we have heart failure with preserved ejection fraction when there are 5 points or more, and we can rule out this diagnosis when there is only 1 point or none. And what about patients who have intermediate scores? Very simple. In these cases, it is recommended to measure hemodynamic parameters of heart failure through non-invasive diastolic stress tests or directly through right heart catheterization. Therefore, we could consider that the stress echocardiogram is conclusive when the ratio E divided E' is higher or equal to 15 and the increase in the peak velocity of tricuspid regurgitation is higher or equal to 3.4 meters per second. For its part, right heart catheterization would be diagnostic when left ventricular end diastolic pressure at rest is higher or equal to 16 millimeters of mercury and pulmonary wedge pressure is higher or equal to 15 millimeters of mercury at rest or higher or equal to 25 millimeters of mercury on exertion. Great! After making the diagnosis of heart failure with preserved ejection fraction, we would only have to identify the specific etiological condition and prescribe the appropriate medical treatment in accordance with the recommendations of the current clinical action guidelines. But as you can imagine, this is material for another video because we no longer have time. This has been all for today at Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!